Welcome to the Empowering Minds Mental Health Podcast, where we explore the strategies, insight, and real life experiences that help individuals and families navigate mental health challenges. Today, we have a very special guest, Dr. Brian Licuanan, who has dedicated his work to helping families break through the barriers of resistance when a loved one refuses help. I'm honored to have you here today, and thank you for agreeing to come up.
Hey, thank you for inviting me. Great stuff you're doing, and look forward to the conversation.
Thank you. All right. So we're going to get right into the questions. All right. So um, you've written a book, and I kind of want to talk to you um, about your book. First, what inspired you to write your book, and what personal or professional experiences shaped your approach for writing your book?
Yeah. Well, the book is called How to Get Your Resisting Loved One into Treatment. It's a step-by-step plan for mental health and or addiction crisis. And where that book came about, which was released last May of 2024, and approaching about the first year. And where that book, the driving force behind that book was a lot of my clinical work, volunteer work, talks that I give, educational support groups that I facilitate. And what I had noticed over time is that these struggles that these family members were navigating through with a loved one who is struggling to either recognize they have a struggle or are resistant to getting help. And these challenges or questions that these families had that they would bring to the table, so to speak, were very, very consistent, and they were just pervasive and consistent. And then I also found that my recommendations for them were also very consistent. And after a time, I wondered, is there not anything out there where a resource that can answer some of these questions? And we know with mental health, it could be very, very diverse and subjective as well. But so I started asking families and even clients, is there any strategy guide out there to help answer some of these questions? And of course, they would say, yes, there's resources, for example, how to set limits and boundaries, or self-care, or talking about the mental health disease or addiction, or even people's own autobiography of their struggles and through the recovery. But there was not a step-by-step strategy guide. And so I found what I was gathering is that there's some missing knowledge out there, or misinterpretations of terminologies or knowledge out there. And so I decided to put together all this information that I've been reciting and communicating to family members in my groups and clinical work into some type of a manual that they can turn to, that can hopefully answer what I believe are some of those missing questions or missing knowledges out there.
So I'm thankful for your work, thankful for your book, because it also helps to break stigmas around mental health. And your work also can kind of help someone have what I call a me versus me, where
Mm-hmm.
they finally kind of accept I have an issue with substance abuse, or I have issues with depression. So I do need to get help. So I'm so thankful for your work in breaking stigmas. All right. So you mentioned a lot about families. So why do so many families feel powerless when trying to get their loved one to accept help? And how can they begin
Mm-hmm.
to shift that?
Yeah. Well, one of the things that I talk about a lot, and if I may just share for your listeners to kind of get an idea of how the book is written, and but one of the biggest, it's probably the most uh, essential part of my book. If I was to say, if there was one chapter of a book to read, if you could only read one, it is my chapter called the 25 Must Knows. And the 25 Must Knows are what I believe is the culmination of, like I mentioned earlier, of all the knowledges that and questions that keep coming up for family members. And so that would be one of the most essential things. And one of the things I do talk about is talking about the disease, we have this very widespread definition of disease, and you may know that there's not one unifying definition of disease. The medical society defines it one way, the World Health Organization defines it another, the American Psychiatric Association defines it in another way. And so there's, my point being, is there's no unifying definition of disease. I like to look at disease. Of course, there's psychiatric, conditions, diseases, post-traumatic stress disorder, depression, anxiety, social anxiety, autism, and so forth. And there's also mental health conditions, right? Diabetes, we have autoimmune deficiencies, and so forth. I also like to expand the disease where everyone can relate, is just some chronic entity in our life that's been hard to manage, and it's caused problems in one or more areas of our life. And so, yeah, my thought is that we all have some form of disease, our own version of a disease. And we, outside of the realms of psychiatry and medicine, things like gluttony can be your version of disease. If it causes problems in your life, and that's a big problem, then it is. If you have um, materialism, right? There's not a psychiatric or medical diagnosis for materialism, but if that causes problems in your life and it's hard to mitigate those, then that's your version of disease. And hedonism, which is the seeking of pleasure, so we all have a version of disease, so we're all some form of recovery. And what I like to look at is I like to personify our disease. There's a saying in the recovery arena, so to speak, like AA, Alcoholics Anonymous arena, is our disease is always in the corner doing push-ups, meaning that this disease is a separate entity than us. It doesn't define us, but sometimes it's so pervasive that we treat ourselves like the disease, and other people treat us the disease as well. If someone's schizophrenic, right, and we start to treat them like schizophrenic, and they believe they're schizophrenic, and then they become defined by schizophrenia, which is not. It's just a condition that's a footnote of their life. And so I like to look at the disease as a separate entity, and I like to use a lot of metaphors. And I look at the disease like this car, and its oil and gas is guilt and fear. And so back to your question of what are some of the biggest barriers for family members to take action, those are two of the most powerful and pervasive emotions that stall families from getting the help their loved one needs. Guilt, meaning that something you have emotions about doing or not doing. For example, if a parent was an alcoholic during their childhood years, they feel guilty. If someone was abused, at a young age, they feel guilty for not protecting them. If someone got a contentious divorce with their spouse and it caused a lot of stress in the kids, so there's guilt, and then there's fear. Fears of, well, God, if we do something, they might hurt themselves, or they may die, they may never talk to us again. So to me, back to your question, guilt and fear, in summary, are two of the biggest barriers to getting help. And of course, lack of knowledge as well.
So my ears kind of tuned up. So I was listening to you when you said about the diagnosis does not define the person.
Mm-hmm.
So I really like what you were talking about is like person-centered language. Not,
Mm-hmm. Yes, for sure.
yeah, so I really like that, making it person-centered. And so
Mm-hmm.
I wanted to ask you, what is, well, I guess we can kind of continue because you were about to go into this. What are some of the most common mistakes families make when dealing with a resistant loved one, and how can they
Mm-hmm.
avoid them? I know sometimes people they even may realize they need help, but they don't
Mm-hmm.
want to be
Yeah.
pushed.
So some of the biggest mistakes that I see families are number one, they make assumptions, right? They make
Yeah.
assumptions about sometimes their condition, and that's what was talking about earlier. Sometimes lack of knowledge,
Hmm.
so they just make assumptions. Sometimes um, a lot of families believe that it takes just willpower, right? That we could just will ourselves out of this. And we know, especially with chronic conditions, or especially with traumas in life or a substance, it takes more than just willpower to white knuckle it. They need community support,
Hmm.
sometimes interventions, sometimes medicinal interventions of seeing a psychiatrist to help with those symptoms. But some knowledge I hear is, well, gosh, alcohol's so bad for you. You're about to get a divorce. You have 3 DUIs. Just stop drinking, right? Yes, cognitively, logically, it makes sense. Or, my gosh, you're in this abusive relationship. Your partner keeps physically and verbally abusing you. Just leave. And so willpower alone is important, but people think that that's all it takes, and it's more. It's deeper than that. It can take significant intervention. Are there people out there who've been able to willpower themselves? Absolutely. But those, I find, are just outliers. Those are just the rarities. Most people need community, sometimes resources, support, in addition to willpower. And so that's one of the biggest um, misconceptions. And of course, lack of education. Sometimes people just make these assumptions about depression, right? Sometimes they just feel depression is, well, gosh, you're not depressed. You're out with your friends a lot. You're successful in your job, or gosh, there's no way you're suicidal. You have like 5 kids. Why would you even think about killing yourself and leaving your little loved ones? Or anxiety, like, well, gosh, anxiety is not that big of a deal, right? Just stop thinking of those anxiety provoking thoughts. And so that creates this very disconnect. People don't feel validated or heard. And so sometimes shame comes in. That's another big emotion, in addition to guilt and fear, is shame. Then we feel shamed that if we share about our struggles, that we feel like we can be judged. And the last one too, there's many, but the big one is sometimes cultural. Sometimes there's cultures. I mean, culture is a great thing, where people come together and they have these common beliefs and norms, but sometimes cultural beliefs can be a barrier. Like if someone grew up in a culture where mental health was seen as a weakness, there's probably going to be some shame and embarrassment to talk about if mental health struggle. Or they grew up in a culture where um, it's we don't talk about it, right? We just keep silent about it, and that can be a barrier as well. So there's quite a few barriers, but those are some of the most common ones that I come across.
Okay. So the last point you made about culture, that is so true. I grew up in an era where we didn't talk about mental health, just kind of kept it within your family. And
Mm-hmm.
personally, I had some things with childhood trauma and adult trauma. And of course, those childhood traumas carried over into my adulthood.
Mm-hmm.
And so as I got older, I started seeking out for help. So now I always encourage people, listen, there's a lot of resources out here for you. So don't suffer in silence. So that's 99% the reason why I do this podcast, because I do want to break stigmas, because you're right, that it is a lack of
Mm-hmm.
knowledge, or people do assume certain things about mental health.
Yeah.
Yeah. So I wanted to ask you, do you have any suggestions on how families can balance compassion and boundaries when they're trying to support someone who struggles with uh,
Mm-hmm.
addiction, depression, or trauma?
Mm-hmm. Yeah, yeah, very good point too. And the first thought that comes to mind is a concept that's out there. It's just that sometimes people misinterpret it or take it to a certain level where it becomes counterproductive. And so the first one that comes to my mind is tough love. And you see that it's meaning well. It was for those family members who felt like they weren't needed to be emotionally tough to really get their loved one to the point of accepting help. What I find a lot with families is they interpret tough love as this very, very disconnected love. Is that, for example, language such as, we don't want anything to do with you until you get sober, right? You're not healthy for our family until you are better, in a better place. And those kind of language for someone who's already defeated, who feels lost and helpless and hopeless, can be very, very detrimental, right? We can open the doors to hopelessness where they want to just end their life. And so I call it more of assertive love. Assertive love is this nice balance between having relationship, which is closeness, intimacy, closeness, and rules is these boundaries. And some of the most, I believe, the most effective, productive, and healthiest relationships is where there's a nice balance between having relationship and rules. Because if you're too rule bound with someone and you don't have any relationship, like, hey, here are the rules, but I don't know nothing about you. I don't really care about you. Most people are going to resist that. If someone is all relationship, that we're buddies, we're great buddies, but there's no really boundaries, people are going to be resistant when it's time to implement those rules. For example, who are you to tell me what to do? You know, let's say, for example, an adult um, drinks with their 17-year-old teenager, and they were drinking together and so forth, and maybe it gets out of hand. The adult is saying, hey, you got to stop your drinking, right? And it's like, well, what are you? You drank with me. And
Right.
so, so, like I said, the best relationships, I call it assertive love, is a nice balance between rules and relationships. So you can come from a loving place with your love, but set boundaries. For example, one of the most common statements that I write in my book, for example, with someone who is probably struggling with guilt to their loved one, is in a scenario would be, hey, I really care about you. We're here for you. It's just that what we're doing isn't working, and I can't continue to support this lifestyle that you're living, whether it be drug use or lack of getting help, right? But we're here for you. So you're telling them compassionately that we're here for you. It's just that the boundary is what I'm going to not participate anymore, is because we're doing more harm than good. And so what it does, it gives the responsibility on the person and it gives them a choice.
Mhm.
Whenever we tell someone what they can and cannot do, you can't drink anymore, right? You got to stop doing this. Our natural inclination is to resist that. And so giving the person the choice and letting them know what can come around, if what is there for them, waiting for them with open arms if they decide to go that route, and what they're going to support if they go the other route. And so that is where you can come with compassion, validation, empathy, but also have rules and boundaries set in place as well.
I like that. Um, and you are right. Most times, people are more acceptive of compassionate language versus
Mm-hmm.
you demanding or
Yeah.
saying statements like you said, you need to stop drinking. I mean, it's an
Mm-hmm.
actual sickness or disease. If they could stop, whatever
Mm-hmm.
it is, they would naturally stop on their own. So I'm glad you gave that analogy there about the compassion
Mm-hmm.
language. So my last question, um, do you have any success stories where um, families maybe they applied your principles from your book and they saw a breakthrough for their loved one?
Oh, yeah. And that's again the impetus of writing my book, is because these interventions that I was giving. So how I refer to myself uh, more recently is a family crisis strategist. Yes, I'm a psychologist and therapist and so forth, but more specifically, this niche is a family crisis strategist. And some people may see that as an interventionist. And so an intervention is usually when you get the family together and then you have your loved ones struggling, and really, put them at the center, and encouraging them or pleading with them to get help, which is very important and appropriate. My angle I come from is, I believe there has to be an intervention on the family unit minus the loved one, because if you don't create change and create a unified vision and a strategy with the family unit, as you may know, things can go awry very quickly. So, for example, if you can get someone to treatment and they're there for 3 months, if they're going back to that same community, a family unit, they haven't evolved and changed, they haven't worked on their own healthiness, for some people sobriety, their own resentments and coping skills or communication skills, the long-term success of that person greatly diminishes. And so that family unit also has to have an intervention where they're recognizing what their role and responsibilities are and things they have to work on. There's a saying in the recovery arena, the 3 C's: you didn't cause it, you can't cure it, you can't control it, but you've definitely perpetuated or enabled it in some form or fashion, even coming from a loving place. And one of my sayings I also say is, just because you're coming from a loving place doesn't mean it's the right or the best place. We can have the best well intentions coming from a loving place, but that loving place can also perpetuates, and that's the essence of enabling, right? Enabling comes from a place of love. It really does. That's what we do. We give someone food when they're hungry. We give them shelter when they have no home. It's just that those actions can perpetuate the issue, right? If you continue to give someone money when they lose their 10th job in 1 year because of their uncontrolled alcohol use, then where's the motivation to get sober or to keep a job? And so that's where enabling comes in. It's coming from a place of love. However, it perpetuates the issue at hand, that problem, if we continue to facilitate that. So, yeah, so those are some of my, um, but the you're asking me about, take me back. Did you ask me about a case?
Yeah, if you had any success
Yes.
story that you wanted to share.
Yeah, definitely. And so one particular one, actually one very recently, where a loved one ended up in jail, and so they were wondering what to do. And so one of the things I write about my must knows is some of the worst place you can end up is some of the best places you can end up. Of course, as parents or loved ones, we would never want or imagine or envision our loved one to be in a hospital or
Mhm.
homeless or yeah, in jail. But sometimes when someone's really, really out of touch and need help, sometimes those are the best leverages that we can have. And so this particular loved one, and this happened on several occasions for with various families, is then when they engage in a behavior and they end up in jail, a lot of times many people don't prefer to be in jail. That's what I find, that many people don't. Are there people that are lifers can do it? Yes, but would they rather be somewhere else? Yes, but I would say 95% of people don't want to be in jail, and so that's a huge leverage. It gets them time to think about things, and sometimes you get a case against them. They can get a probation officer where they're required to be sober, or sometimes they'll be required to do mental health treatment or get into a program, conversely, and not go to jail. And so yes, I told the family members, keep them in jail, do not bail them out, right? And so I had a case recently where the person was so unwell that whenever he would call his family members, why am I not out? Why am I not? How come no one bailed me out? Why am I still in here? And the plan was, no, let him stay in there, let him think about things. And now they're seeing a shift. Now things are starting to settle in, and like, okay, they're realizing that there's a boundary set here. And so they're seeing a change of tone of voice, and he's more open to the other options on the table. And so that's a particular one. Sometimes if they're homeless, there comes a point where they hit such a point of desperation that, okay, I don't want to be homeless anymore, I'll do whatever you say. And sometimes getting help, there's a research shows that people who are forced into treatment or getting some types of help can be just successful as people who are not. Is it because there's this window of ailment or illness where people need to get treated for it? Of course, in the first few weeks, they're resistant, they're withdrawing from substances, they have
Mhm.
anger. But over time, as they get sober and healthy and stable, they start to have the therapy. They start to have these realizations like, wow, my family does love me. I don't hate my family. Oh, wow, I want to live life. I don't want to die. Or, wow, alcohol is really a problem. And so that's what I do is I get the family members to a point where they get their loved one to that window of opportunity where the possibility of change can happen.
Thank you for that. Um, so I want to leave these last few minutes with you. Um, if you will please share about your book, where people can purchase your book, if you want
Sure.
to share any contact information or anything like that, and if you have any final resonating thoughts that you want the viewers to capture from this.
Yeah. Well, thank you for that. And well, here's a picture of my book. It's like I said, there it is. That's what it looks like. Most easily, you can get it on Amazon in Kindle and paperback form. Also, my website is a great way to find my book. There's an excerpt there and direct link to my book, as well as sort of media appearances and education that I have on there. And that's at no space, no caps. It's drbrianlicuanan.com. And I'm assuming you'll probably drop that on
Sure
the
will.
description. And then Amazon, and I'm also on Instagram. I have mental health posts on education there at Dr. Licuanan, and at TikTok at Dr. Licuanan, and on YouTube at Dr. Brian Licuanan. So, yeah, so that's some of the best ways. And so, to your question is, what's a take home point? And it's the biggest one, and it was the another driving force to my book, and it's literally my must know number one, the very top one, is I communicate to families to have hope. is because I know a lot of families feel helpless and hopeless out there. They feel like they've tried everything, but chances are you haven't. You know, the trust, it's just that the strategies need to change. And you have to have hope. I've dealt with some really bad cases where clients attempted suicide, literally a real attempt of suicide 48 hours before coming to treatment, or people had chronic drug use for decades, or severe traumas, you know, sexual abuse, child abuse, abandonment, um, parent passing, and so forth. And people are able to get better. They really can and live a healthy life. It's just that the strategies need to change. And so when I say treatment, treatment isn't necessarily the formal process of treatment residential, because for some people it's difficult, affordability, but it also means how to get your resisting loved one not only to treatment, but how do you get your resisting loved one to a place where they can accept help? And because there's all kinds of ways of recovering. Some people, they need an inpatient, hospital, residential treatment, intensive outpatient. Some people, their churches have a modality or approach, or some cultural religious beliefs have their own approach. So it's really geared towards getting your loved one to a place where their only option is to seek help. And that's what I strategize with the family with, is to come together and come up with strategies to hopefully get their loved one to that place of accepting help, surrendering.
Well, again, I want to thank you for coming on. I want to thank you for helping me to shift and empower minds. And I'll be in contact with you soon with your links.
Thank you so much.
Take care. Have a good one.
Bye bye.
Thanks. Bye.